Good morning, everyone. Today we will be presenting a case from emergency department where the learning objectives will be an approach to acute severe anemia in emergency room, difference between intravascular and extravascular hemolysis, management of acute hemolysis in emergency room. So we have Master S, a 2-year-old male child, resident of Punjab, admitted for 4 days, came with the chief complaint of fever for 4 days, sudden onset of pallor for 1 day, hematuria for 1 day, and rapid breathing for 1 day. In history, child came with a history of high-grade fever, which was documented around 102 Fahrenheit. There was no chills and rigors, no rash, which was relieved on taking oral medications. Along with that, there was pallor, which was insidious onset, progressively increasing with easy fatigability and difficulty in breathing, along with the passage of cola-colored urine in cola-colored urine. There was no history of any other bleeding manifestation, no history of joint pain, rash, abdominal pain and distension, no history of any cough, cold, chest or chest pain, no history of blood transfusions in the past. And other history, child received oral amoxiclav on OPD basis on day 1 of illness, admitted in private hospital for 1 day before coming to PGI, where child was diagnosed to have severe anemia and was referred to PGI. Birth history was significant with the neonatal jaundice on day 2 of life, which was child received phototherapy for 4 days. There was no other major illness or hospitalization after that. Developmentally, child achieved all the milestone as per age. Immunization was complete as per NIS. And family history was there was no history of any jaundice, gallstone or splenectomy in the family. When child came to triage, initial physiological classification was unstable and life-threatening. Airway was open and stable. There was tachypnea, acidotic pattern was there, and saturation on room air was only 80%, which was increased to 90% on 100% FiO2. Circulatory-wise, child has sinus tachycardia, and in disability, GCS was 4 with E2, V3, and M5. Pupils were 2 mm reactive to light, motor activity was normal, and RBS was normal. On exposure, child temperature, child was afebrile, there was pallor, and there was ictus. There was no other surface finding. On general examination, there was moderate to severe pallor, ictus was present, there was no clubbing, cyanosis, lymphadenopathy, edema, or skin bleeds. Child had weight and height, which was normal for his age. On systemic examination, per abdomen, there was abdomen was soft, non-tender. There was hepatosplenomegaly with liver 2 cm below right costal margin and spleen 2 cm below left costal margin. There was no ascites, bowel sounds were heard. Respiratory system, bilateral equal air entry was there. There was no added sounds, and CNS was within normal limits. CVS S1 and S2 was heard. Gallop was heard, and there was no murmur. At the end of history and examination, we have a 2-year-old male child with sudden onset of pallor and high-colored urine following a viral prodrome. The initial possibility of severe anemia with suspected hemoglobinuria with jaundice was suspected. So whenever a patient come with an acute onset of anemia in emergency room, we have to understand that oxygen delivery will depend upon cardiac output, hemoglobin and saturation, and small contribution from partial pressure of oxygenation. So in case of severe anemia, even in context of a good cardiac output and normal oxygenation, severe anemia can lead to decreased oxygen delivery to the tissues, which was evident in the index case by a lactate of 18 at admission, suggesting severe tissue hypoxia. For that, supplemental oxygenation and child was planned for urgent blood transfusion. When we talk about severe anemia in etiology, there are 2 reasons by which severe anemia can occur. There can be loss of RBCs and there can be lysis of RBCs. When we talk about the loss, there should be history of like epistaxis, hematemesis, hemoptosis, melena, or trauma, or any bleeding from any site on examination. We suspect lysis when there is jaundice, hemoglobinuria, splenomegaly, and previous history of any transfusion, family history of gallstone or splenectomy. In the index case, the history of loss was not there, but jaundice, hemoglobinuria, and splenomegaly was there. When we talk about lysis can be extravascular or it can be intravascular. When we talk about extravascular, the lysis of the RBCs, it occur in radiculoendothelial system, in spleen and liver. And when we talk about intravascular, it is inside the vessels only. And in intravascular, there will be hemoglobinuria and hemoglobinemia. So in extravascular hemolysis, there will be jaundice more than that of intravascular. Urine color will be normal, no hemoglobinemia and no hemoglobinuria will be there. In the intravascular, jaundice will be there, cola-colored urine or hemoglobinuria will be there, and hemoglobinemia will be there. In both these cases, there will be increase in the LDH and RT count. So in the index case, jaundice was there, color urine was there, and hemoglobinemia was there. When we talk about intravascular hemolysis, the initial etiologies which were thought were G6PD deficiency with drug exposure or infection, immune-mediated hemolysis, malaria, or toxin-induced. In the index case in investigation, this 29 December investigation is from outside, where a child HB was 6.5. When child came to us, it was 3.5 mg per deciliter. On peripheral smear, there was mild anisocytosis, normocytic, normochromic red cells along with the microcytes and macrocytes. In other investigation, the total serum bilirubin and conjugated variety of bilirubin was increased, LDH was increased, and plasma HB was high, urine HB was present, DCT was positive, 4 plus for anti-C3D antibody, negative for anti-IgG. G6PD was normal. So final diagnosis was 2-year-old male child with sudden onset of pallor and high colored urine following a viral prodrome. Initial possibility severe anemia with query hemoglobinuria with jaundice, and acute intravascular hemolysis was thought, most likely autoimmune hemolytic anemia, and mostly triggered by an infection. So whenever such a case present to us, the goal of treatment is to correct the severe anemia and to prevent the AKI. To correct the severe anemia, we need urgent blood transfusion, and to prevent AKI, maintaining renal perfusion, and to prevent, we have to maintain the renal perfusion and we have to prevent the pigment nephropathy. So for transfusion, we have to transfuse the PRBCs in aliquots. Transfusion should be continued till there is no ongoing hemolysis. In case of an immune hemolysis, problem of compatible blood may arise and least incompatible blood should be transfused. Once DCT is positive, immunotherapy should be considered early in case of a warm type of autoimmune hemolytic anemia. The second goal is hydration, adequate hydration to maintain the renal perfusion and to prevent the pigment nephropathy. Fluids can gradually be relaxed after a blood transfusion. In selected cases, forced diuresis and renal replacement therapy may be required. The third important step is monitoring, where we have to monitor urine output, hydration status, and cardiac status. Hemoglobin monitoring should be done periodically and more frequently if it is indicated. Reticulocyte count daily and direct antiglobulin test weekly in severe cases. So course and management in emergency. For anemia, child was transfused 1 unit of PRBC at 15 ml per kg within 2 hours, and child total received 30 ml per kg. For hemoglobinuria, IV maintenance fluid was started at 60% of maintenance, which was hiked to 150% after transfusion. So these are the representative images that we took from internet. So initially there was child had dark color urine, and by the end child urine was looking like the final image. So for further course in ER, child did not receive any further transfusions. Urine output remained above 1 ml per kg per hour. Hemoglobinuria was settled and pediatric hematology consultation was taken, and plan was to follow up in OPD. So when we talk about the autoimmune hemolytic anemias, hemolytic anemias are result from antibodies directed against the PRBCs, against the RBCs, and they can be of different varieties, like the warm reacting autoimmune hemolytic anemia, which is responsible for 65 to 70% of such cases. Cold agglutinin disease, paroxysmal cold hemoglobinuria, and mixed type of autoimmune hemolytic anemia. Also, it can be classified as primary and secondary. In the primary, there is no underlying disease as such, and constitute about 40% of such cases, more common in young children. When we talk about the secondary causes, secondary autoimmune hemolytic anemia, there is some underlying disease like an autoimmune disease, immunodeficiency, or some infection triggering that, and it constitutes around 60% of autoimmune hemolytic anemia cases, and more common in adolescents. This image tell us about the two mechanisms by which the autoimmune hemolytic anemia occur. In the first one, we can see that it is a warm antibody induced, and what happens is that the IgG antibodies are directed against the antigens on red blood cells, and RBCs are destroyed inside the reticuloendothelial system like spleen and liver. In the cold variety, what happens is that IgM antibodies are directed against the antigens on PRBCs, and lysis occur intravascularly. Also, predominant antigen in case of warm is Rh, and in case of cold it is capital I and small I. Predominantly IgG is involved in warm, and in cold it is IgM. lysis occur at the body temperature, that is 37, and in cold agglutinin it occurs at a low temperature. Site of hemolysis extravascular, intravascular, and in warm antibody, DCT is positive for IgG, and in case of cold agglutinin, it is positive for the complement. The steroids are first line therapy in case of warm antibody, and they are less effective in case of cold agglutinin. Immunoglobulins are the second line. They have a poor response in cold agglutinin, and rituximab has good response in cold agglutinin. So the take-home message is that acute intravascular hemolysis is an acute hematological and renal emergency. Urgent blood transfusion is the first step to correct the severe anemia and maintain tissue oxygenation. Second is hydration and monitoring to maintain the renal perfusion. If there is some difficulty in cross-match, that can give us clue that it can be because of immune-mediated hemolysis, so we can thought about his immune-mediated hemolysis early on. And early steroids should be given in case of warm immune-mediated hemolysis. Thank you.
We have Dr. Deepankar to join here and give your comments, if any.
We brought up this case to highlight the importance of. So we brought up this case to highlight the importance of diagnosing the etiology of acute severe anemia in pediatric emergency. In this particular case, it was autoimmune immune-mediated hemolysis. So whenever a case of immune-mediated hemolysis comes, there are mainly two principles of treatment, mainly urgent blood transfusion to maintain bare minimum HP, and then to maintain the renal perfusion to prevent the pigment nephropathy. And if we get clues from blood bank, we should consider this possibility early, and early steroids can be life-saving in this case.
Okay, we can open this for your